Okay, let's get started. So it's 29th April at 11 a.m. in Singapore. And on behalf of the Sing Health Duke-NUS Global Health Institute, I'm delighted to welcome all of you today. I'm Amina Mahmood, the Deputy Director of the Institute, and this seminar is part of our monthly seminar series in which we discuss important topics in global health. Our goal has been to build a community of like-minded global health enthusiasts and practitioners in Singapore and well beyond Singapore. I must start with saying that today is a bittersweet moment for me. I've always been very, very happy to share our wonderful speakers with our audience, and our audience has grown into quite a varied group who kind of consistently log in and participate in our seminar series. But for me today, this is the last seminar series that I'm hosting, as I'll be moving on from the Global Health Institute just from next week. And I'm particularly delighted to host our speaker of today, who is Associate Professor Ashley St. John. Ashley was our very first speaker when we started this monthly series in 2019. So for me, it's coming kind of full circle that Ashley is with us again today. And she had, going back to 2019, Ashley was a new faculty in our institute. And I remember reading her background and thinking, wow, she's doing amazing work, which is so pertinent to global health. And we must provide a platform for her and others like her to share their work. And, you know, the monthly seminar series was started then. And we held it live in those days. And I remember that first day, the room had a capacity for usually had 30 plus people in it to sit down. And we had more than double the number then. Everyone was standing around in corners. And it kind of showed the latent interest of global health on the campus. So here we are today. Now, of course, we are online and we have many more people. And this format allows us to go off campus also. So many months later, we have Ashley speaking to us again, and it's a real pleasure for her to be the last speaker that I will introduce for the Institute. And to get around to introducing her fully, the whole thing, many of you do know her. She's an associate professor at the Duke-NUS Medical School, and she's principal investigator of the Laboratory of Immunity and Immune Pathology in the program in emerging infectious diseases. She also holds appointments in the Department of Microbiology, National University of Singapore, and the Pathology Department at Duke University. And as I mentioned, she's faculty of our institute, and she also leads our doctoral scholars global health track. Ashley received her BS in Applied Biology from the Georgia Institute of Technology in 2004, and her PhD in Immunology from Duke University in 2010. She then went on to complete her postdoctoral training at Duke-NUS in 2014. She's an expert in viral immunology and focuses on immunity to vector-borne pathogens such as dengue and Zika viruses. She also has an interest in immune responses to respiratory viral pathogens and has been involved with work on the SARS-CoV-2 virus. Her lab works on developing novel vaccination strategies, diagnostics, and therapeutics for infectious and allergic diseases. And today we'll hear some of this work applied to Nepal. And I'm happy to say the Institute has been this work has been funded by our Institute. So I greatly look forward to her presentation and thank her again for being with us. Before I hand over to the audience, as you may know, the webinar is being recorded. Please keep yourselves on mute. Questions will be addressed at the end of the presentation, but you can put them at any point in the chat and we will look at them. So Ashley, over to you.
Thank you so much, Amina. And I also want to just mention as I'm pulling up my slides that it's a bittersweet moment for me as well. And I really appreciate your guidance and support through these past few years with SDGHI. And really, a lot of our conversations have truly inspired me to take a more global health perspective on the research we're doing. So yeah, today I will be talking about a specific study that I've chosen because it was funded by SDGHI, and I want to, kind of give back some of the data that we have generated and show you how we've been able to work with SDGHI to further some of the goals of, developing global health research projects in Asia. So I also want to mention that I put a little checkbox at the bottom if you want. Obviously this is being recorded, and if you want to comment on what I've been saying publicly, that's perfectly fine with me. There are a couple slides that are not published yet, and I indicated those at the bottom, but otherwise everything is open. So I want to talk about dengue today. which we know is an extremely important global health concern. In 2013, it was estimated that 3.6 billion people were at risk for dengue infection. And we know that it can lead to quite severe disease. So depending on the quality of healthcare and other aspects related to risk factors, between 1 and 30% of cases in a given outbreak can actually even be fatal, or and many infections are quite severe. In parts of the developing world, children are particularly at risk for infection. And we also know that other groups are also at risk, such as travelers and military personnel. So what happens when you get dengue? Usually we think of dengue as having this two-phased disease course, where initially after a mosquito bite, there's an incubation period where you might not even realize you're sick. Then eventually, almost everyone will develop a febrile illness that usually resolves, and viremia. But towards the end of disease, as viremia is beginning to subside, there's this risk of hemorrhage or shock that can occur, usually right as people might be starting to feel better. And the question is, has been for the dengue field, who are these people? How do we identify those who will progress to severe disease? And of course, dengue can be a huge strain on the healthcare system. This particular image is from Bangladesh, but this is a common sight throughout the world, particularly in the tropics and subtropical regions that are prone to dengue outbreaks, where during an outbreak, we can see a huge strain on the healthcare system. And there's this question of which of these patients can be discharged and which need to be retained for further monitoring. So I want to emphasize that dengue has a very wide range of disease severity. So many individuals actually even experience asymptomatic or subclinical infection. They may not realize that they had dengue and later, recover without the knowledge that they were exposed to dengue. Of course, those who are asymptomatic or have subclinical infections contribute very substantially to dengue transmission. But most of the people that experience a symptomatic dengue infection usually have a resolving case of dengue fever, where there's a mild febrile illness, and they may or may not need to be hospitalized. They could be treated as an outpatient and recover. And for a very small proportion of patients, really the tip of the iceberg as shown here, they may develop into DHF or DSS, dengue shock syndrome. So what are the signs and symptoms of dengue? Usually, as I mentioned, the mild disease is characterized by fever, headache. There might be mild bleeding, such as of the nose or gums, and skin manifestations, I should say. Rash is one of the most common signs of dengue infection. But some patients who experience vascular complications, they can be quite severe. They can experience hemorrhaging. They can experience pleural effusion, so difficulty breathing as a result of the fluid pooling in the lungs. And you can see in these images from an autopsy on the left how severe the hemorrhaging actually can be in certain cases. So in A, we can see the gut. In B, there's a cross-section of a kidney. In C, we can see the liver. And in D, those are actually the lungs. I think the lungs are probably the most apparent to those who are not used to looking at organs, because you can imagine that those are not supposed to be so blood-filled, and there's really quite a lot of hemorrhaging associated with these organs. So how do we treat and manage dengue? Currently, the standard of care is really just supportive treatment, and this usually involves fluid replacement in its most common form that allows the fluid volume that has been lost from the blood vessels in the process of the leakage that occurs to be replaced. But as I mentioned, there are obstacles to achieving the best strategy. Obviously, hospitalization is expensive. It's difficult to decide during an outbreak who receives those scarce resources. And access can also be a major obstacle, particularly in places where people live a long way from supportive healthcare treatment, it may be difficult for them to reach in time because dengue can, progress very quickly, even within a few hours. So the WHO came up with some ways of trying to determine which patients are going to develop the most severe form of disease. And this involves monitoring patients very carefully for warning signs. Some of the warning signs are shown here in the middle panel, where you can see abdominal pain and tenderness, persistent vomiting, clinical fluid accumulation. So this can be something like a tourniquet test, or it could be otherwise identified through something like ultrasound. Lethargy and restlessness when this is really quite severe, liver enlargement, and of course, these hematological parameters, such as a rapid increase in hematocrit, concurrent with a decrease in platelet count that could indicate coagulation defects and vascular leakage. So, see if we can go to the next slide. There we go. I also want to highlight that these are the new criteria from 2011 that the WHO issued that actually, prior to this, clinicians described the more severe forms of disease with dengue as DHF, so dengue hemorrhagic fever. And those criteria are a little bit different, and I want to highlight them because later in the study, in the talk, I'm going to emphasize how we compared the two different clinical definitions. So most of the DHF definition revolves around aspects relating to the vasculature, thrombocytopenia, for example, and hemorrhagic tendencies. So these can involve things like pleural effusion. But nevertheless, whether or not the diagnosis is DHF or severe dengue, the clinical disease is very similar. And the problem that can result from dengue that is most common in severe cases is this aspect of hypovolemic shock, where you can imagine that loss of plasma from the blood into tissues and organs can lead to a situation where there's insufficient blood volume for the heart to really continue pumping sufficiently. And this can lead to shock, and conversely, I should say, that plasma that has leaked into tissues and organs can also cause organ damage. And so these are the two end stage of dengue, severe outcomes that really go hand in hand. So how do we identify those patients that are going to experience severe disease? I think it's important to highlight that there are many risk factors that have been identified. So some of these include pre-existing conditions. For example, diabetes, obesity, asthma are some of the ones that are most closely linked to being a risk factor for developing severe disease. Another factor would be pre-existing immunity. In the case of dengue, we know there are 4 different serotypes of dengue. And after infection with one serotype of dengue, you can still be subsequently infected, unfortunately. And this results in a situation where multiple serotypes of dengue can co-circulate in a community or exist sequentially in a community over time. And when we have pre-existing immunity to one serotype of dengue or maternal immunity in the case of infants that have received maternal antibodies, these antibodies can cause harm. And this is one of the most strongly linked factors to severity. However, it is important to note that primary dengue patients do still experience severe disease. And then I don't want to leave out that there are certain genetic factors and gene polymorphisms that have been associated with severe dengue, but to date, none of these has really effectively been used for dengue prognosis. So we can't, just by understanding the patient's medical history, identify who might experience severe dengue. But I want to tell you a little bit of the background on the basic science that we started doing, trying to understand dengue disease. And when I started working on this, when I first came to Singapore, I thought I didn't know very much about dengue. It's not a major risk in North Carolina where I was, and I had only thought about it in the context of knowing about it in general, but not really thought about the pathophysiology of the disease much. And so when I started hearing a lot of talks in Singapore about the symptoms that people experience with dengue, I thought it's interesting that many of these signs and symptoms occur in the context of allergic diseases as well. And so you can see on the left, a patient with rash due to anaphylaxis, and on the right, a patient with rash due to dengue. You can also see pleural effusion due to anaphylaxis on the left and pleural effusion due to dengue on the right. And although it's important to emphasize that these are different diseases, they have a different clinical presentation in many aspects, and they also have a different disease course, whereas dengue takes quite a long time to develop severe disease, anaphylaxis happens very quickly. I still thought it's interesting that many of these signs and symptoms were shared. And in allergic diseases, we know that mast cells, which are very specialized immune cells that are important for immune surveillance in tissues, those are very integral to the mechanism of allergic diseases. So that when mast cells release these granules, which you can see in the image on the bottom right-hand side, those granules contain many pro-inflammatory factors that can diffuse into the environment and act on nearby blood vessels, as well as other immune cells to promote a pro-inflammatory state and to influence coagulation. So some of those mediators include things like histamine, which you have probably heard about to a great extent, but histamine is only one factor that mast cells make. They also make factors like TNF, many specialized proteases, leukotrienes, heparin, which you may know is involved in coagulation, and others. And these can break down tight junctions between endothelial cells. They can reduce clotting or alternatively promote intravascular coagulation, and can be quite damaging in the context of widespread systemic mast cell activation. We also, in beginning to interrogate how mast cells respond to viruses, we found that dengue, unlike many other viruses, triggers mast cell activation. So you can see on the bottom in the control tissue, a resting mast cell where all of its granules are stained green. It's in the skin, and it has not been activated. And then on the right side, when we add dengue, we can stain and find infected cells, which are highlighted in red here. And nearby, the mast cells that are proximal to infected cells are often very highly activated. And you can see this mast cell has begun to release its granules, which you can see with the punctate staining. Mast cells also line blood vessels, and they're found in very close proximity to blood vessels. So you can see in this image of the skin, blood vessels are in blue, and mast cell granules are stained in red. So you can see these mast cells are really tightly associated with blood vessels, even touching them in some cases. So I highlighted the mast cell products that can act on the vasculature previously. And again, I just want to emphasize that there are so many products. We think that a lot of these are working in concert, but we're particularly interested in the proteins that make up 90% of the mast cell granules, which are tryptase and chymase. And these are proteases that can break down tight junctions between endothelial cells. They also can be found in the serum, and because they're made only by mast cells, we like to use these as biomarkers of mast cell activation so that we can identify if a mast cell has been activated in humans by testing for these serum levels of these proteases. And I should say, if you can detect them in the serum, it really indicates that there's pretty widespread mast cell activation. So just one quick piece of data to show you that we do think mast cells are important for the vascular leakage. This is data in the mouse model where we infected mice with either with dengue, and we infected mice that were either wild type mice, normal mice, or mast cell deficient mice. We call those SASH mice on these graphs. Or we reconstituted the SASH mice with mast cells. We gave them back their mast cells. And then we measured vascular leakage following dengue infection. So in the top panel, we measured the hematocrit. And I just put a little diagram of a test tube to the side so that you can see that when you centrifuge down the blood, it separates into the red blood cells that form the bottom layer, and then the plasma on the top layer. And you can imagine that in a patient who has experienced vascular leakage, this plasma has leaked out through the blood vessels, through those tight junctions that are weakened between blood vessels. And this percentage of the blood that is erythrocytes or red blood cells will increase as a result. And so you can see that in the graphs here, mice that are infected with dengue that have mast cells have a significant increase in their hematocrit, whereas SASH mice that lack mast cells do not. And this really shows that mast cells are important for the vascular leakage that occurs during dengue infection. We did that with a second technique as well, where we injected a dye and measured the dye leakage into tissues, and that's on the bottom. So in animal models, mast cells seem to be important, but what about in humans? And so the first question we tried to address, we looked in retrospective samples from Singapore, from patients that were dengue positive or dengue negative febrile control patients, or healthy controls, I should say. And we measured their serum kinase levels. So you can see that on the graph here, that all patients that are dengue positive, or almost all, had measurable increases in serum kinase. And this shows that everyone who is dengue infected with symptomatic dengue seems to really have some level of mast cell activation. And we know that it's truly mast cell activation because, as I mentioned, this product is not made by any other cell types. But we were very surprised to see that not only were mast cells activated, they were correlated, their activation levels were correlated with disease severity. So you can see that on the right-hand side, dengue hemorrhagic fever patients had much higher levels of kinase compared to those that had dengue alone. And I should also mention that this was a surveillance study. So the sample was taken as soon as the patients had presented at the clinic and not during the acute phase of disease. So these patients would have not developed DHF later and later have been designated as having DHF. So this is interesting, but it was a retrospective study. We had a small subset of patients that we could look at from that study, and we were curious if we could identify whether kinase could be prognostic for severe dengue and other cohorts. And the first set of data we obtained on this related to the Dengue Tools Project, and this was a collaboration that involved faculty from Duke-NUS, including Dwayne Gubler, and the Ministry of Health in Sri Lanka. And so you can see that, this is an image from 2014. Our samples were collected about 2011 to 2015. So they were experiencing really high levels of dengue at that time. And so although this was a febrile illness study, and not all of the samples were dengue positive, many were, due to the prevalence of dengue in the region. So in order to look at these samples, we selected them from the larger cohort based on having a discharge diagnosis in the study database of having dengue fever or dengue hemorrhagic fever. And some samples we couldn't use because, as I mentioned, they were used for some other purposes. However, these were all confirmed dengue samples, and we had a good range of patient ages, from young children all the way to elderly. So when we measured kinase levels in these serum samples, we found, again, very consistent with our data from Singapore, that patients with dengue hemorrhagic fever had significantly higher levels of serum kinase than dengue fever patients had. And because of the way the samples were collected and graded, we also were able to identify patients who didn't quite meet the diagnostic criteria for dengue hemorrhagic fever, but they still had some signs of bleeding. So this would be something like a nosebleed or bleeding gums. And those patients also had significantly higher levels of kinase than the dengue fever patients, really suggesting that kinase levels do correlate with disease severity. I'll just mention how this looked over time in terms of the day after fever onset. We saw that patients, from day 3 through to day 6, all had significantly higher levels of kinase, no matter what day it was, during this transition between acute to resolving dengue disease. And the kinase concentrations were also significantly higher for all age groups, whether the young or the elderly. And I should mention, we didn't have enough patients to truly look at elderly. So it's above 45, which when I accidentally say elderly, sometimes people get upset with me. But yeah, indeed, it seemed to be consistent for all of the age groups we investigated. So then the next question for us was, these were samples that were taken when someone presented at a clinic. Oops, sorry. But we had another question, how the kinetics change over time. And for this, we wanted to be able to take longitudinal samples from patients. And we worked with Professor Minori at the University of Colombo to obtain some more samples from a pediatric patient cohort. And so these patients were recruited, they were hospitalized, and as they were hospitalized, we took sequential samples so that we could chart how kinase changed over time. So you can see now in the top left-hand side, again, this is a different patient cohort, and we do see a significant increase in kinase in patients that have DHF compared to dengue fever. And even so, this occurs even though the patients don't have a difference in the amount of dengue that can be detected in their serum. So on the right-hand side at the top, you can see a graph comparing the viral titers between patients with dengue fever and DHF over time. We also reclassified these patients according to the new WHO criteria. The process of reclassifying patients based on the symptoms with DHF to severe dengue in our cohorts, and in my experience, usually takes some of the DHF patients and converts them to just dengue fever. So, really severe dengue consists of the very most severe patients in the DHF scoring system, those that would have higher grades of DHF. And so when we compared this again, we saw that patients with severe dengue had very significantly higher levels of kinase at later time points. When we also had, because of these patients were hospitalized, there were other routine tests that were run on them, and one of them was an ultrasound. And so we were able to understand whether the patients had pleural effusion or gallbladder wall thickening, which is also associated with severe vascular leakage during dengue infection. And in patients that had these two conditions observed, again, we saw higher levels of kinase than in patients where this was not observed. So again, kinase is associated here with measures of vascular leakage. So overall, if we look at the samples with fever less than 3 days or less than 4 days in Sri Lanka, we can see that kinase is a very strong predictor of DHF. And these are the two ROC curves for those two different studies. So now I'm going to get really into the point of what I wanted to discuss today, which is the study that was funded by the Global Health Institute to study a cohort of primary dengue patients in Nepal. And really our primary goal was to begin to describe dengue in Nepal in more detail. This is an aim that I had with my good friend Barindra, who we had been discussing for about 6 or 7 years how we wanted to work together on a project. And so I know it's very difficult for those of you working in the global health sphere to find funding that allows you to bridge different countries, different communities, and really work together to build some of these platforms. And I want to take a minute just to emphasize my gratitude that the Global Health Institute saw the value in our project and helped us get this started so that hopefully we can continue this. And so our goal was really to build capacity in Nepal as well. And at the same time to determine if serum dengue levels correlate with disease severity in this cohort, whether these results that we've seen in Sri Lanka and Singapore are more broadly applicable to other populations. So I just want to take a minute and describe Nepal. When we think of Nepal, I think everyone really thinks of these areas that are in blue with the beautiful mountains, Mount Everest, for example, and all of the lovely lakes and hiking experiences you can have in Nepal. But this particular study, we're looking a little south of that. So the terrain changes beyond the mountains, south of the mountains, where you can see that there's a region of hills that are really the foothills, and there's a lot of agriculture there. And then there's an area called the Terai, which is something that's a bit unique to the Indian subcontinent, where this word actually means marsh. And it is marshy in places, and other places it's like pastures and plains, for example. But this transition region is a place where dengue has been surging in recent years. And I think you can imagine that this type of environment, particularly during monsoon season, is susceptible to surges in mosquitoes and continued dengue transmission. So we wanted to use this as a location to study dengue in more detail. This is one of Virendra's maps of Nepal, where you can see that at different, over the course of about 10 years, there have been increases in this area. It matches to the hills and the Terai region in cases of dengue. And he particularly chose a site for our study called Darhan, which is shown here. And I think you can see that I'm pointing to a province where there had not previously been reported cases. And I want to emphasize how important it is to work with, really integrate the local knowledge into your study design, because I would not have chosen this particular location to try to recruit dengue patients, but he knew some things that we did not. So first of all, the number of cases in dengue are rising, and you can see how this really surged in 2019, which was unfortunate for Nepal, but it was helpful for our study because our samples were actually collected in 2019 during this huge outbreak in dengue. And you can see, some of the news stories, local news stories at the time, that Darhan was seeing this unexpected rise in cases that was becoming a healthcare burden in the area. And so I think his insight early in the season that there were cases in Darhan and it was getting out of control helped us really identify a very successful study site for this. And this is just an image of how Darhan looks. You can see it's at the foothills of the Maharbat range, touching the edge of this Terai region. And you can see here are some hills and how it's flattening out with the city in the valley. This is one of the hospitals that was a recruitment site for us. So you can see it's here in blue, Bijayapur Hospital on the left-hand side of this image. And you can see this is just a normal street in a mid-sized city in Nepal, where patients who don't feel well can just arrive at the hospital and go in. I think that we had another study site as well that recruited similar patients similarly. And so once we got these samples and our case report forms back, Sid in my lab, who is a new MD PhD student, wanted to take on this and really try to learn about dengue and understand the outbreak in Nepal. So he started doing the lab work to support the larger study that Virendra and I had designed. And the first thing he reported back to us is that this was a dengue 2 outbreak, that although all these patients were confirmed to be dengue positive through some method, including potentially like NS1 detection, which is a viral protein, when we got the samples back to the lab, we were able to PCR confirm about 2/3 of them. And that's about a normal range for PCR confirmation in a study. And all of them were dengue 2 positive. I was a little surprised, but we also saw that all of the patients were primary dengue infections. So they hadn't been exposed to dengue before. And I think that this really reflects an interesting aspect of our study, because previously we had looked at samples in Sri Lanka, for example, where about 2/3 of the patients were dengue immune and had previously been exposed to dengue. So this allowed us to really understand, outside of the context of secondary dengue infections, whether we could see changes in our biomarkers. And I also want to just highlight one of the other, adventures in doing research in a different, location. And that relates to this interesting finding. So Sid came to me and he said, something's wrong with our spreadsheet, because how is it possible that the date of fever onset makes sense, but the date of birth is in the future? And I also thought, well, did our spreadsheet get corrupted? What could have possibly happened? And we went back to our collaborators in Nepal who explained that, there they actually report their birth date based on the Vikrami calendar, which is a calendar that's based on the Hindu belief system and very different from what we're used to. So we were able to ask them to translate this for us. And I think this is also emphasized once I checked the hospital's website, they also celebrate holidays according to this calendar as well. So 2021 Holi was actually 2078, and now our data makes a little more sense. So once we were able to analyze that, how that looked is that we had a really even split between males and females. Actually, this surprised me as well. A lot of times when we recruit in other locations, we see that we get more males than females, and we think that that likely has to do with the fact that many of the people who are exposed to dengue usually have occupational hazards where they may be outside and working outside. And it tends to be skewed towards the male gender in Sri Lanka, at least. And we were a little surprised here to see pretty even distribution of men and women. Also, we saw that our cohort is very young overall. We recruited all adults and even teenagers that were able to provide, consent to us. But most of the patients are in this 20 to 40 range, and so young adults. And then one other interesting aspect is that we saw no severe dengue in this cohort. And this was a little bit of a surprise to me, but at the same time, I think it makes it difficult for us to really analyze associations with severe disease, although we got around that in some ways I'll show you in a minute. But at the same time, I think it probably reflects the unique demographics of who was exposed to dengue in this particular case, because we're seeing a lot of primary dengue, and we're seeing a lot of young and healthy individuals who probably don't have some of the pre-existing conditions that we have recruited in other patient cohorts. However, I do want to emphasize that not everything is severe dengue. You can be quite unwell, and it may require hospitalization, even if you have other signs of disease. And particularly, these warning signs are very alarming. So things like clinical fluid accumulation, abdominal pain and tenderness, and then other hematological parameters, they gave us the opportunity to identify patients that had more severe disease without it meeting the WHO criteria. And so if we look at these warning signs and we do a multivariate analysis, we were able to identify some that were very significantly associated with kinase levels. So for example, many aspects relating to pain, so muscle pain and abdominal pain were significantly associated with elevated kinase. And so was our neuroseverity score, which involved neurological complications. So in general, when we look at the warning signs, we also see that a good number of patients did experience warning signs. So you can see here the frequency of warning signs, having multiple warning signs. And while almost all patients had at least one warning sign, there were some that experienced multiple warning signs. And this shows that I think that the supportive care that they were given probably was effective in preventing severe disease. So we tried to look then at the correlation between the number of warning signs that the patients experienced and serum kinase levels. And you can see that there was a significant correlation, so that patients with a elevated serum kinase tended to have more warning signs present. We were also surprised to see that the serum kinase levels were very strongly correlated with the volume of fluid replacement that the patients received, so that patients who needed more fluid replacement usually had higher levels of kinase. So with this, I just want to emphasize that when we're talking about risk factors for severe dengue, we think of these things like pre-existing conditions, immunity to another serotype of dengue, genetic factors, gene polymorphisms. And so why don't we see severe dengue in this cohort? I tried to touch on that a little earlier, we think that, this is a really young, healthy population, and they have primary dengue. And I think by setting this baseline in this community, I'm hoping that we'll be able to continue to monitor how dengue looks over time. We can see that it is manageable, and although people do experience, some of the warning signs for severe disease, largely they did not progress to shock or true severe disease by the clinical definition. So I think it will be important as dengue continues to circulate in Nepal to continue to monitor this. And then I just want to mention something about dengue prognosis, because this is an important aim of our project, is to understand whether we can use biomarkers to identify patients that are at greatest risk for disease. And our data in Nepal also supports our previous findings that perhaps looking in this early window of 2 to 4 days, which is prior to the onset usually of the shock or bleeding complications that people with dengue experience, is, I think, a viable way to, improve triage for dengue patients, or at least identify those patients that might be at risk for very severe disease who are about to slip through the cracks and be discharged. And I think that's one of the biggest concerns, is that, if someone is sent home, can they get back to the hospital in time if their symptoms progress further? And so we hope that this data can go a long way towards supporting that biomarkers for dengue severity are valid also when you look in primary dengue patients. And so with that, I'll just highlight a few of the key players. Of course, Sid in Chiang Mai, Chiang Mai guided Sid as he was learning how to do a lot of these assays, identified, the serotypes for the study and performed the laboratory analyses. And Sid has also been working on trying to do more in-depth statistical analyses lately. So we hope to be able to update this and continue to provide more information on this patient population. And very importantly, I want to highlight Virendra, who was essential for the study design and has been an outstanding collaborator. And I think, a testament to our aim to build capacity, we have, another study ongoing that we managed to get funding for on COVID. So we're hoping that we can continue capitalizing on this project going forward. And with that, I think I can wrap it up and, of course, answer any questions you might have.
Great. Thanks so much, Ashley. That was good.
Thank
Great
you.
spread of, quick crash course on dengue and what we can even think about it. So to the audience, as we mentioned, please put any questions you have in the chat box. And maybe while people are thinking of it, I'll kind of start off with a question, Ashley, that I had. I was actually thinking of it all through your presentation of, yes, this will be great to know it, but how does it, get translated into clinical practice? What changes can you see? You touched on that towards the end, but can you elaborate further on that and maybe even think about, do doctors need specific kind of training, like really how does, in a very practical sense, I know I always push you on this, that you guys do great science, but how to make it practical?
Yeah, so, I'll say, I'm not a clinician, so I would really welcome if anyone else has a comment as well. One thing I would say is that when we're looking at things like biomarkers, it's very easy to test for them in some contexts. Like, I can imagine a rapid test for this type of biomarker like this. It's not so hard to test for it. We've been doing it with BioELISA, which gives us a nice quantitation, but I can envision tests that complement the dengue tests that currently exist. We know that dengue tests such as this, NS1 test is a rapid test as well. And I can imagine that it would be not too hard to add biomarkers such as chymase to it. There are other biomarkers that I didn't have a chance to talk about today that we're excited about as well, some that seem to predict shock specifically a little better. And we're quite interested in trying to develop those types of things further. I see another question from Paul. The first question, did we see this in our ketidin cohort? So maybe I'll go ahead and answer that one. So yeah, we have this ketidin study, which is to try to use mast cell stabilizing drugs to improve dengue outcomes. And our data is still blinded. We did measure chymase in those samples, and we see a range of chymase. We don't see it. I don't think we see any that are alarmingly high, which I think is consistent with our overall patient cohort for that study, where we only had 1 or 2 that might qualify as having a severe disease. But while it's still blinded, I would say we certainly see a range, and I think it's going to be interesting to see whether those levels are reversed. One of the things that I would say to tag on to that is that chymase we've chosen partially as a biomarker because we think that it has a fairly long half-life, and it's possible that mast cell stabilization could reverse the levels of chymase, but it's also possible that they might persist a little longer than some of the other mast cell biomarkers. So while we're interested in trying to see whether chymase could not only be prognostic, but maybe a tool to understand how the treatment, whether a treatment is successful, I think we'll have to evaluate that down the line.
Thanks. I'll read you a few other questions that come into the chat. Maybe I'll start with the ones which are more focused on this study, and then there's some more general ones.
Sure.
So you have a question: how can you be sure that these cases in Nepal are primary dengue? Was this serology done before, or the other immunological markers?
That's a good question, and I should have put a slide in, but usually we can tell by measuring the IgG levels. So IgM, of course, is an antibody that comes up very fast in response to infection. So we get dengue-specific IgM very early in dengue infection. It can't be used to identify whether the patients have primary or secondary, but in combination with IgG, which doesn't come up until really the tail end of the disease course, you can identify patients that have high levels of IgG. That means that they've previously been exposed to dengue. Because the antibodies to dengue are cross-reactive, we'll still see those come up, even though they can't really protect the patient very much. And so that's how we define a primary versus secondary dengue. Sometimes, can it be difficult to read? Yes, sometimes there's a little bit of a judgment, like you wonder, okay, well, these antibodies are coming up. Is it early enough? Did they report their date of fever wrong? So occasionally there could be some gray area, but on this particular cohort, we didn't see any. So we're pretty sure that all of these patients were dengue negative.
Okay, thanks. And then there's another question relating specifically to the study. Why was Vijayapur Hospital with small setting selected? Although there's a hospital at, I'm not sure what this is, but BKIHS Dharan with large clinical setting. So I guess it was just a larger hospital.
So I would say that I actually can't fully answer that question because this was the groundwork that Barendra did. I don't know, but I think he was hoping that what we would be able to do is have the clinicians who have time to do this. Perhaps he knew someone who was excited about it, but I'm actually not sure why we chose the very specific sites that we did, other than he was had connections to do that and to get patients at those sites. Yeah, but I think that's a good question, and certainly I hope when he presents this at some stage we can ask him.
Yes, but sometimes you do have to just go with what you will be able to access.
That's true.
So, yeah. Then there's a question that kind of makes you think about maybe the longer term, and what are the next steps that you're planning in terms of follow-up studies?
Okay, so I think I would really like to expand this a bit. We have about 100 samples from this particular area, and I think that having more samples might give us some more robust analyses we could do. I also think that it would be interesting to see if we can understand the rates of severe dengue, because we saw so few severe dengue cases. And I wonder if that's also part of the study site, because this is a smaller hospital. Maybe some of the more severe cases would have ended up at a larger hospital. So, I think we have a little bit more to do in terms of understanding the patient cohort. And of course, I'm pretty excited about using biomarkers. So I think it would be nice to do a true study, a true clinical trial where we could try to see if it does improve patient care. And I think that is something that is, beyond the scope of what I would do myself, and hopefully can work with other partners to do something along those lines that's on the wish list in the future.
Okay, and again, I'm kind of jumping around the questions a bit because I'm trying to keep some train. So thinking of other studies, I guess, and the larger issue of working in places like Nepal, you're asked, were there major regulatory or ethical issues doing a study in a LMIC as in Nepal?
So I would say for this particular study, it's non-interventional, so we didn't have too much trouble. Of course, there are still requirements to submit to the IRB and things like that. And we didn't really have too much trouble. I would say Barindra's like magic and handled it a lot on his end. But I would say that, recently I've been involved in a clinical trial in Nepal that, was much more difficult. So we do have to submit a lot of documents through their National Medical Research Council. There was a lot of back and forth. And I think there is a little bit of concern, rightly so, to make sure that they're true partners in the process of doing this research, and that it's not just coming to test a drug in a lower middle income country, as you mentioned. That's not what we want to do. We want to make sure that it's when we're doing studies, it's something that could have the potential to benefit the local population. And I think this study, we hope to provide some insight into what happens with dengue and whether these biomarkers could potentially be used there. In the clinical trial we're doing, we're also hoping for a drug that could potentially improve patient outcomes when there's not an opportunity to take other drugs for the condition that's common there. And so I think that those are the types of issues that we have to work through ourselves, but certainly the regulatory authorities do make sure that we have.
Yeah. No, but I absolutely echo kind of the line you took. There's one issue of, yes, what is the paperwork and what is the documentation and what is the, and that's fine. And, you will work through it. But the kind of broader context is what's the benefit to the local population? How is it feeding back? What you already mentioned this, what capacity building elements might they be? So it's not just it's not an extractive relationship, but it's more of a true partnership. But turning back, we have one more question, and that kind of takes us back to the beginning almost when we started the question and answer, is that if you did have a kinase POCT, as you mentioned, how much of a heads up could such a test provide to the clinician in terms of a patient which may quickly deteriorate towards severe dengue and SHA?
So, I think that's what we really need to test that in a clinical trial for me to say it with confidence. But I think that the fact that we have used serum samples that are really from the moment that the patients were presented and were enrolled, shows that these are not markers of the deterioration stage alone. They seem to be truly prognostic for events that might happen a few days later. And that's why we're so excited about them. Because usually these patients have not, and in fact, we've excluded them when they've arrived and met the definition of DHF already. And so only patients that have mild or moderate dengue at the time of enrollment have been recruited to these studies. And I think that's a key point. So yes, we think it should be able to give a heads up if it works as well as it seems to in these biomarker studies, but of course a trial will be needed.
Yeah, great. We don't have any more questions at the moment, so I'll just take this chance to, for one, thank you, Ashley, again, for not only this presentation, but all the great collaboration we've had through the last few years. I'd like to take the opportunity to thank the team, which, has been such an amazing kind of support through all the seminars we've had. And I think we've always managed to kind of have a pretty seamless and kind of well-organized seminar. So I feel quite happy with that. And I look forward to now continue to participate in these as a, participant in the future. And thank you all to the audience, as always, for being with us. It's always such a pleasure to have you. And this online format just opens up this opportunity, to involve so many more people. It's a wonderful experience. So thank you all, and look forward to more of this.
Thank you, Amina.